Welcome to the Health Focus Podcast, brought to you by Memorial Healthcare, where we discuss current trends and topics in healthcare that are important to our local Shiawassee community. We are coming to you, as always, from the Now Building and our podcast studio. I will be your host, Dr. Gregory Flermone, a general surgeon here at Memorial. With me here today is Dr. Rami Kurdi. Dr. Kurdi, thank you for joining us. As an orthopedic surgeon, why don't you tell our audience what you do and what you bring to our community?
Thank you for having me, Dr. Flermone. I am an orthopedic surgeon, so we have different subspecialties. I'm a general orthopedic surgeon, which means I cover multiple areas of trauma, sports medicine, and joint replacement. And we're here in the community. I've been here for about 3.5 years. I've got some amazing partners, and I'm proud to be part of a program that's in a hospital system. It's over a century old, and I'm actually very grateful for the staff that we have and the communication we have, and especially with trauma. And thank you for all your service.
No problem. Yes, actually, with the addition of Dr. Kurdi and Dr. Albana, who you most likely heard in our most recent episode, we've been able to keep a lot more trauma here, and that has been beautiful because, as Dr. Kurdi, has talks about our century-old healthcare system, we want to keep people here in Owasso. So what gets you going in the morning? You say you don't have a specialty, but what wakes you up in the morning you're happy to do, brings you to Memorial every day?
So, in terms of subspecialties, it's subspecialties specifically reserved for unique surgeries that are not very common, but 95% of everything that walks in a general orthopedic or subspecialist office who takes general call is a general orthopedic problem, which includes fractures, trauma, arthritis. Young people can have early onset disease. We do diagnose occasional rare diseases, but basically if you have pain, you hurt yourself, whether it's trauma or some chronic insidious process, something slow moving that is just bothering you, or you have any reason for musculoskeletal concerns, we're here to help. We get you in the door and we find the right place for you, or hopefully a non-operative treatment plan, but sometimes surgery.
We like to touch on that with all of our surgical specialties. We're not just here to operate. We like to cut, but that's not the right choice for everybody. What are some other modalities besides surgery that you can offer the patients?
Yeah, and I agree with that. I think that if you need surgery, we would like to project that confidence that you're in the right place, that we're the right surgeon for you and it's the right diagnosis, and that when we do it, we love to do the best job. But absolutely, I have just as much fulfillment seeing a smile on someone's face, knowing that they can avoid surgery. The biggest thing is, I'm always excited about this. Mm-hmm. I always tell you, you can call me when I'm not on call. Mm-hmm. I just love this job. When I come in, I'm excited to see patients. I look at every individual like they have a problem that I can't begin to pretend to understand in 5 or 15 or 30 minutes. But I can focus on their major complaint. What brought you in here today? And sometimes it's just a matter of education. Patients just want to know if what they've already had done is good enough, or are they missing something? Oftentimes it's just, have they been heard? So I love for patients to rehearse questions and have the right ones there, but we have a pretty good technique of trying to get the right answers out of the patient by provoking the right questions.
Other modalities you can use. How important is imaging, physical therapy, injections, how does that all tie together for a patient coming to see you?
So it does. The biggest thing is not everyone can have the same problem, and everyone comes from a diverse background. So same person with the same problem, but a different history or a different age or different demands is going to have potentially different treatment options. And the biggest thing that we do is educate patients. I want you to know what I know in the best possible way I can break down the knowledge base so that you understand the treatment options, the risks available with any treatment. What happens if you don't do something? Sometimes the worst thing you can do, surgery is not a last resort. It's often regarded as a last resort. Surgery should be the best resort when it's reserved. So if you have an early trauma and you want to see how you do with an ankle fracture that's unstable, you're not going to be happy. And if it takes you 9 months to realize that your ankle is very deformed, we missed the window of opportunity to treat you, which is the golden window within a few weeks, or 2 to 3 weeks, preferably under 3 weeks. So the idea is that do you know what I know, and I need to know what you know that is relevant to the problem so we can come with the best solution. So physical therapy is huge. Therapy has different plans and outcomes. I think every patient is different, so the biggest responsibility of a patient is to be transparent about what they do every day and what their demands are, and also about what they got done for their homework. Try to explain to people that we share an interest in your outcome, and I'm only responsible for the part I can put my hands on and educate you with. And the patient has to execute their end of the bargain, which is, preventative medicine or the therapy requirements, home exercises, nutrition, avoiding some habits that we need to break. So it's a mutual bond that we arrive at together.
Yeah, the patients need to meet us halfway sometimes because they have things to do for the best outcomes. And you touched on something interesting, and I learned this a long time ago. Surgery sometimes gets referred to as the aggressive option, or you have the conservative option. And so people think, we're being conservative, we're not operating. like with that ankle fracture. The conservative thing is probably to operate because the outcomes are better that way. And so we get that a lot in surgery where, oh, you just want to cut me. And no, that's not true. We need to figure out the best way to get what goals you want achieved. And a lot of times that's surgery. Sometimes there are other non-operative managements. So I know from what I've seen on the board, you do a lot of hips and knees. That seems to be your bread and butter, seems to be, at least what's coming through the door for you. Walk me through, patient has an old sports injury, something like a bad knee, kind of what's that process of them seeing you to getting to the OR, kind of, and then we'll touch on a little bit later, but your specialty with the Mako robot, kind of how does that all tie together for somebody with a bad knee, for an example?
Sure. Now I'll start with the knee and kind of reference the hip a little.
Okay.
It's, there's this big kind of like misconception that if you have bad knee arthritis and you've had it for years, that you could be 30-something, you could be 40-something. One of the older misconceptions is I have to drag my knee until I'm 55 or 60, or these implants only last 10 years. And now we have modifications in terms of the plastic component of the worn out component, the parts that wear out within 10 years previously, just to simplify it, can last 30 years. They tested it mechanically in a lab. So they took the 10-year implant and cycled it at a certain weight, at a certain speed, nonstop, 24/7 for 6 months. It wears out. And the newer implant goes a year and a half, 3 times as long, the 10-year wear rate. So obviously it's not been around 30 years, but we project that longevity. So I try to educate patients that, listen, it's what can we do to get you better? We have lifestyle modifications, so sometimes you can't run, right? So if I give you a knee replacement, you probably shouldn't be running. It's not ideal. So we're not making you better with a knee replacement just with the running factor. So but you can't even do your daily activities. You can't go to a barbecue, So to summarize, we allow patients to realize that their options are not limited to age. The American Academy of Orthopedics recently made a very profound statement that it is joint replacement is not limited or restricted to age. It's patient history, their clinical exam, and their radiographic presentation. X-rays, how well can you move your knee, and pain. Have we tried other options? And the options are injections. There's different types of injections, and therapy, weight loss, things like that.
Is there a weight barrier to some of these replacements? When we were in med school a few years ago, we learned if they're too obese, knee replacement, it's not even an option because it's not going to work. It's not going to get them to the functionality where we need to. Has that changed at all recently?
Yes and no. So it depends, again, on the patient's health. It's just the overall picture. Okay. So I always like to project the number one idea, and it's hard to really fathom because we're all human, but you walk in our room and you answer our questions, you are not to be judged. It's weight gain is a problem, and weight loss is very difficult. Smoking is a problem. Quitting smoking is difficult. I don't care when we just started develop these habits that are negative. We're not here to judge you. We're just here to help you. And how do you be your best you? Well, we don't start out by judging you as an individual. So we have a new weight loss program with Dr. Jeannie Cody, which I'm excited about, and I'd love to see that.
Okay.
I would love to see more revolutionary, treatment plans for diabetes, smoking, and weight loss. Those are huge. But yes, so in answer to your question, weight loss is essential. We need a certain BMI, but you can be well overweight and still have a knee or hip replacement. And it's also important to see that there's a measured loss and that you have a plan that's sustainable, that's healthy. So someone with a 39 BMI but has lost went from a 53 BMI can have a knee replacement.
It shows they're going to be able to reach their end goals easier because they're already motivated or working towards those things. The Mako robot, we have our own Da Vinci robot, and we were very excited when you brought this on scene here. Kind of talk about that. What does that offer the patients and you as a surgeon that can advance these replacements?
When we have complications with hip and knee replacements, it's often related to alignment or positioning. So what the Mako robot does that a human eye cannot do is it's accurate to a third or a fourth of a millimeter.
Okay.
So when you position a cup in a hip, the angle of the cup and the depth of penetration bone is there. And we have to assess it with the naked eye. We can do, again, fantastic work. But where longevity matters is like an alignment in your tires. Your tires last longer if you actually have a good alignment. So with all due respect to my predecessors and anyone who practices surgery without a robot, we do not need a robot to do an excellent knee replacement or hip replacement.
In regards to the Mako robot, what does that bring to the table for your patients and for orthopedic surgery as a whole?
Well, we have done an excellent joint replacement for years, both knee and hip. So what the robot adds is precise measurements. The biggest problem with complications in knee replacements or hips is mechanical instability or malalignment. And the robot adds a 1/3 to 1/4 of incremental measurements where we position our implants. So patients have better outcomes, and we have studies to prove that they have less complications, less pain in some cases because it's less invasive. We don't have to involve tools that position cutting blocks. We can do that out in space. It's actually a haptic feedback, which means that you pull a trigger and you try to do your measurement and make your cut, and it falls only within the parameters that you measured. So without the robot, the naked eye measures in maybe 2 millimeter increments for recutting. We have diminished the need for recutting to begin with, and the incremental measurements are, again, fractions of millimeters. So really proud to offer that. Imagine there are a lot of, again, so many great surgeons out there, and my colleagues are doing spectacular work, and I encourage the robot. It's just a better tool with the most optimal outcomes for patients doing the same surgery.
So you talk about less pain. Does that equal less time in the hospital as well?
Absolutely. Okay. Yeah. We have about 99% same day or next day discharges with both total hip and total knee replacement.
Is there anything extra for the patient that goes along with this that a typical, I don't want to say typical, but a non-robotic joint replacement would, more incisions, less incisions, kind of, what would the patient notice different or different workup?
The pain scores are strongly more related to the technique of the surgery, not the robot. So a direct anterior hip replacement will cause significantly less pain for a longer period of time. So the recoveries within 5 to 7 days, people are markedly better than they would be with other approaches that require taking down tendons. So less restrictions with a direct anterior approach to the hip, which is not Mako related.
Okay.
But I do that along with the Mako.
Okay.
But with the knee replacements, they're like on the scale of 1 to 10, they're incrementally less consistently, but not a lot less. Knee replacements do hurt. We do coach patients through it and provide appropriate pain management during the recovery process.
Do you see quicker return to work with the Mako as well, or maybe that's more the anterior approach on the hip? Because it seems like a lot of these patients, they don't want to be down for a time. They want to get in, get out. They want that quick fix. Do you see that a little bit with the Mako too, just quicker return?
I wouldn't want to make an anecdotal reference to that because I really believe in transparency in terms of data and research. And the transparency is with the data present is that people are doing better on pain scales minimally comparatively, but they are going to have less complications, less return to surgery and implant positioning issues, so instability, things like that, dislocations with hips. Return to work is related to the patient in general. How well they move preoperatively, how healthy they were preoperatively dictates a lot of their postoperative range of motion and activity. But the truth is that if you think of alignment, when you think of any mechanical movement, tires in a car, any pulleys or machines, the idea here is that the better the alignment, the less wear. So Mako, I would say, is the greatest, other than minimizing risks and having excellent range of motion, is to promote longevity. Even wear. When you wear out a product, or whether it's your knee or an implant or your hip, that it's more concentric for a hip, it's more even for a knee, and that it will last longer because of that.
Like a well-balanced tire.
Exactly.
So it seems like that with the better implants, the longevity of all this seems like it could be exponential. When you start adding better alignment, now you have that 30-year implant versus a 10-year. Now you get those younger people, you can get them on their feet, they can work longer, be better productive to society. So that seems great.
Absolutely.
As we kind of wrap up here, is there anything else we haven't talked about you want to let our community know about you and the orthopedic program, or anything that you see around here?
Well, we're eager to help. We have an incredible facility here at the Now Center, and we have all the technology that you're looking for. The most important thing I'd like to promote is kindness, transparency, honesty. We're going to do our best in the short time we have to get to know you and your problem, your focused problem. And if it's something that we can offer you, the top tier service, we're going to offer it to you. And if it's even falls short of that in any direction where it requires a subspecialty referral, we may have that in network, we may not. We'll make sure that we get you in the right hands. So the biggest thing with patients for us is we want them to feel open with their communication, to be able to reach out. And I want them to know that myself and my colleagues are here to provide that service to you and make sure that you come in with more informed and that you leave our service and our treatment plan better for it.
Excellent. So that brings us to the end of our most recent episode. Again, Dr. Curdy, thank you for joining us.
Thank you for having me.
Thank you for listening to Health Focus. If you've enjoyed our show, please make sure to rate and review us wherever you listen to your podcasts. Again, this is Dr. Flermone saying thank you, and we'll talk to you soon.